and employees. We create digital campaigns to make sure that we are constantly engaging with them. We also created a chat box system as well as polling to make sure we understand the current needs. And we also have personal consultation through our PSA agents. And in the back end, the platform is supported by a ticketing generation system, which helps the user get the help that they actually need. We also have response to consultations. This is not only through our PSA agents, but also counselors that are actually specialized in the matter. And we also have indicator dashboard that help us visualize what the current trends are and the gaps. And we have reporting tools for management, project management purposes. And lastly, the continuous improvement loop that help us stay active and relevant. Next, please. So we're going to make a quick virtual tour presented by our Director of Central America, Karen Pavon.
Gracias por el espacio. Hola, mi nombre es Karen Pavon, directora de Centroamérica para el Código Internacional, y el día de hoy seré su guía en este recorrido virtual. EmpleandoMentes es una plataforma digital que ofrece una conexión 360 con el usuario, desde la generación de contenidos interesantes en salud mental y empleabilidad, hasta la experiencia uno a uno con el usuario. En la mayoría de los casos, estudiantes de la red IPC, agentes y el equipo experto en salud mental. Para hablar sobre la plataforma, le doy el pase a Eva. Ella es nuestra asistente virtual y ella le dará un toque más tecnológico a esta experiencia. Hola Eva, comencemos con el recorrido por la plataforma, ¿te parece?
Of course. Let's get started. EmpleandoMentes consists of a website and 3 social media accounts: Facebook, Instagram, and YouTube. Together, these channels currently engage a community of over 2,800 individuals who have access to informative and educational content aimed at reducing the stigma surrounding mental health and highlighting its importance in achieving a better quality of life. Our content includes carousels, blog articles, short videos, live thematic webinars, and more. These resources are designed to encourage interaction across different channels and connect users with our expert team for free guidance or counseling related to the program. Our primary channel of engagement is through direct collaboration with the ITC network, our local partner, which comprises over 20 educational institutions in rural areas of Honduras. A group of teachers from these institutions have been trained in psychological first aid, equipping them to recognize signs of distress among students and refer them to our professional support team. These teachers, known as PAP agents, engage in conversations with the students to assess their needs, apply psychological first aid tools to provide immediate crisis support, and escalate the case through our help desk system. This enables our psychologists to initiate a direct care process, offering up to 10 free sessions, contingent upon receiving consent from a parent or legal guardian. Our system only stores demographic data and case categorization to support a better understanding and modeling of the program while upholding the confidentiality between the patient and the psychologist.
Gracias, Eva. En 2024, EmpleandoMentes dio un paso más allá del trabajo virtual, con la creación de la primera edición del concurso Proyéctate Saludable Biomeme. Los jóvenes fueron los principales actores para comenzar a derribar los muros y estigmas en contra de la salud mental. Empezaron a generar conversaciones honestas acerca de la importancia de la salud mental en la vida de las personas y sobre el cuidado y el soporte que debemos tener y debemos dar para tener una sociedad más empática y más solidaria. Este es solo el comienzo. EmpleandoMentes es una plataforma activa y abierta a la innovación. Issa, Regresamos contigo para hablar más sobre los resultados y el futuro que proyectamos. Gracias por el espacio, Issa. Hola, mi nombre es Karen Pavon.
Okay, let's talk about reach and engagement. Through social media and youth-led campaigns like the one you're seeing here, Proyectate Saludablemente, TV spot context on mental health, we were able to see the beginning or shifting in numbers and the narrative. We were able to reach about 2,800 followers through our social media platforms like Instagram, Facebook, and YouTube. In regards to the content, or the context, sorry, we were able to get 40 teams registered for the content. And 81 participants actually completed the journey and submitted 22 spots for the competition. But this was just more than the participated in the event. It was a behavioral change. It was a way for us to reduce stigma and engage with them in a way that they actually understand. And in terms of the result or the impact, as you can see, 73% that engage in the content, so a very positive outcome. But we also have to understand that their participation also made them people that were able to resonate the message on mental health among their own communities. Next one. Okay, let's talk about livelihood services. Of course, mental health or mental well-being is not the only part of the picture. We want to make sure that they have or they need real pathways to opportunity. Through EmpleandoMentes, we provide employability skills and soft skills training. They reach about 1,100 students, all of them on 10th grade and above. 80 of them completed internship and 44 of them secured jobs. This is about 55% of job placement rate, which in comparison to other similar programs, that actually rated about 15%, with an average monthly salary of 23% higher than the national minimum wage. Let's talk about the mental health services that we provide. It begins with identification. The psychological first aid agent that is embedded in the schools identifies the student who might need emotional support during in-person interactions, these on day-to-day interactions. Then the agent provides psychological first aid directly to students in need. Then after providing the first aid support, one more. Yep. The agent follows up with the student to better understand their situation through one-on-one conversations. And when necessary, the PFA agent refers students to licensed psychologists for additional support. Each student receives between 5 and 10 virtual sessions free of charge through the EmpleandoMentes website. This obviously with parental consent, as it is required to begin the therapy sessions. And in terms of impact, we see that 86% of the participants said their emotional health was very good after receiving care. And in terms of, go back, by the numbers, so you can see on the bottom of the presentation, the breakdown of the mental health services provided. Over 1,100 students were trained on mental health. 154 received psychological first aid, counseling sessions, and for those that required more specialized support, they received short-term therapy, as well as cognitive behavioral therapy. Next. Okay, bear with me, because I think this is important to share with the people that are actually working with youth. What we have learned in this first year of implementation is the integrated approaches work. Combining mental health support with employability and life skill training is key. Those who receive both are more resilient and job ready. We want to make sure the students or the people that are benefiting from the program not just find jobs, but we want to support them, keeping them, and finding a pathway to be promoted in their jobs. Technology expands reach. The EmpleandoMentes platforms embedded access to mental health support and job placement resources for a wider audience. We need to understand that technology opens the door, but in order for us to maintain that door open, we have to continuously connect with the audience. Ongoing support is definitely needed throughout the intervention. Partnerships with private sectors are needed to ensure sustainability. When employers champion inclusive hiring, it helps reduce stigma and create more welcoming workplaces through improving retention. Okay, let's talk about what we're calling EmpleandoMentes 2.0. In terms of what's next on livelihood support, we want to integrate artificial intelligence in providing support to create CVs that resonate or translate day-to-day work that perhaps will not be perceived an actual work experience and translate it into those. And this is where Skill Up comes in. I'm going to give you an example. Think of a young farmer that has been helping his family business for years and not an actual official job. What Skill Up is doing is helping translate the work that the person is doing, helping their family, and then translated it into what is currently needed in the market. We don't want to change the story, but we want to help them tell it in a way that resonates with the employers. Next, please. Okay, this is basically all the steps that Skill Up does. So the first step is actually engage with youth, right, through the social media platforms. Then help them build their CVs through the integrated artificial intelligence. Then 3, we want to make sure that using AI, we are able to match the candidates with skills and interests. And we want to make sure that there's a career path and learning path. We want to engage with the private sector to engage in more inclusive hiring for non-traditional talent. And then finally do the accompaniment needed. Again, not just because we want to make sure they get jobs, but they are also trained to make sure they keep their job and they excel at what they're doing. In terms of mental health, we want to expand our digital servants, providing more one-on-one counseling. We want to be advocates at a local and national level, using the stories and the data we've been able to collect through the implementation of the project. We want to continue doing engagement campaigns with youth, but we also want to make sure that the parents are included since they play such an important role in the lives of the youth. We want to support local networks, and we want to strengthen mental health service provision. We want to make sure that they have employability and job readiness support to connect those two services that we provide through the platform. Thank you so much for your time. And if any of this resonates with what we have discussed, please feel free to scan the QR code, and we're happy to respond to any questions or engage with you to see how we can collaborate not only in Central America, but also anywhere in the world. Thank you.
Thank you so much, Issa, for that wonderful presentation. I will invite Esther Rodriguez to present around Learning for Humanity, a transformative e-learning platform for Catholic sisters and frontline health workers. You're welcome. We'll have 10 minutes.
Good afternoon, everyone. My name is Esther Rodriguez Miranda, and it's a joy and an honor to be here and present on behalf of Medicines for Humanity and our initiative, Learning for Humanity, or as we like to shorten it, for H. Our starting point in this conference has been, what does it mean to be a change agent in global health? For us, the answer begins with Catholic sisters, women of faith already serving in the world's most fragile communities. They run clinics, they manage orphanages, deliver babies, comfort the dying, and advocate for the forgotten. They are not only caregivers, they are leaders, educators, and advocates. And you may be wondering, what is Learning for Humanity? L4H is an online education platform designed to provide Catholic sisters and frontline health workers in general the tools they need to lead lasting change. Through localized training, we help them build sustainable solutions from within their own communities. We start, and we always say the same thing to each and every of our students. You know what your mission needs, and you know what resources you have. We'll help you create something with that. Our mission at Medicines for Humanity is to save the lives of children under 5 and their mothers. But we know this cannot happen without addressing the root causes, without empowering communities, strengthening health systems, and investing in their capacities. L4H is not just a learning platform. It is our strategy for building resilient, justice-centered health systems led by those already on the ground. When we launched L4H, we had 2 key questions. First, can e-learning be a truly accessible and effective tool for sisters and health workers in low-resource settings? And second, does this learning translate into real-world confidence, competence, and leadership? 5 years in, the answer is yes, and it's much more than we imagined. To date, we've served over 1,590 students across 442 congregations with 2,500 enrollments in 15 learning paths. Our courses are offered in English, Spanish, and French. Additionally, our students have a 78.9% completion rate, which is significantly higher than e-learning courses, which average around 60% of a completion rate. These numbers matter, but for us, what matters more is what they represent. Thousands of sisters and workers completing multi-week courses while managing clinics, caring for children, leading parish ministries. They do these courses when they have time, at night, on the weekends, in the mornings. I am with them all the time, accompanying them on WhatsApp, so I can attest to the fact that they work all around. They are busy all the time. Next. Since our launch, Learning for Humanity has experienced a very steady growth every year, bringing in more students, more engagement, and more learning opportunities. We began with just 2 learning paths. Today, we offer 15, ranging from healthcare management, project management, monitor and evaluation, nutrition, and maternal and child health. We currently serve students in over 40 countries. Anyone can enroll worldwide, with the highest enrollments in Zambia, Haiti, and Cameroon. Notably, countries like Nigeria, Zimbabwe, and Lesotho have a completion rate above 90%, which demonstrates a strong engagement even outside of our funded partner countries, who are students that often pay for these courses. When we develop courses, we use human-centered design, regional case studies, and adult learning principles to ensure that what we teach is grounded, relevant, and applicable. Each path connects content to the context of the mission. Every learning path is accessible. It's assessed through pre- and post-course evaluations. We measure both knowledge gains and self-efficacy. That means how confident the student feels applying what they've learned. In healthcare management, for example, self-efficacy rose from 63% to 92%, and in leadership from 71% to 91%. What sets L4H apart is our commitment to growth over time. Our learning paths are scaffolded from foundational courses to advanced applications. A student might begin with healthcare management and then go into project management and later proposal writing or economic strengthening activities. Over 400 students have progressed through multiple paths. For example, 58 sisters have completed 8 or more courses, and we have sisters who have completed more than 11 courses. And this is what happens when education is accessible, driven by the service to others and community rooted. Learners come back, not because they have to, not because they're obliged, but because they see their results in our program. And now, what does that look like in real life? These are just some examples. In Zambia, Sister Judith mobilized 28 volunteers to address child malnutrition. 10 children were treated and 8 made full recoveries. In Haiti, Sister Francelin launched a local latrine initiative through community outreach. grant writing and budgeting. She did it all by herself. And she went to the major and she went to the community and she got everyone involved. And now 10 families have latrines. In Nigeria, Sister Cynthia cut clinic wait times in half by streamlining roles and processes. Also in Zambia, Sister Kabule brought clean water and solar energy to 700 people through a borehole and a solar panel project. Sister Priska secured funding for labs, vehicles, and housing, and then trained others. She's now a mentor to new learners. And Sister Vivian reduced neonatal deaths from 39 to 14 through respectful maternal care and daily triage coordination. And I just want to point out, Alpha-H does not grant or give money to the sisters. We provide them the tools for them to develop these projects, and we accompany them in their implementation through our commentaries or suggestions, but they're the ones going out there and getting the funds and becoming independent on their own. Each of these sisters is a change agent, rooted in faith, empowered by knowledge, and leading with purpose. And what is next? We have mentorship. We're expanding mentorship cohorts where students refine projects, receive feedback, and translate learning into solutions. This isn't an add-on to a learning path. It's the next evolution of L4H, building communities of practice. Sisters are not learning alone. We're making small groups of 8 to 10 students where we come together every week on Zoom meetings. We share experiences, we share progress, and it becomes an international network of peers, sharing ideas, solving challenges, and nurturing one another in mission. Finally, none of this would be possible without our L4H champions, national associations, global networks, and religious institutes who support and amplify sister leadership. Partners like Sisters Associations, ACHAP, CRS, CHAI, the Daughters of Charity, Sisters Risings, and others have held open doors. And now that they see these projects, they're funding sister-led projects that are faith-rooted and community-driven. And that has been one of our major accomplishments, to see the congregations wanting to support the sisters on their project. As I conclude, I want to say to those gathered here, imagine if every sister had access to training that is relevant, rigorous, and rooted in their reality. We wouldn't just see better outcomes, we'd see transformation from within. These women are already the salt of the earth, and we want to equip them to shine as the light of the world. So with that said, I invite you to come talk to me and become an L4H champion or supporter. We'll be happy to talk to you and, just share more about this program. Thank you so much for your attention.
Wow. I was about to raise my placard for that time, but you really, really, really kept time. So thank you so much, Esther, for that. In context where there's scarcity of human resources for health, I think it's important for us to think about e-learning, which can be able to bridge the gap. So thank you so much for that. And I'm sure that we'll be able to get in contact with you. So next in line, I would like to invite Melissa Edmiston, who is the Vice President of Programs at Hope Rises International, and she'll be able to present about empowering health systems with portable PCR technology on this. So you're welcome.
Good afternoon. I am here presenting on behalf of a colleague who could not be with us, which I'm happy to do so because this project is one that we are very excited about at Hope Rises International. So as mentioned, I will be sharing about the Biomeme device, which is a portable PCR that we use in the diagnosis of neglected tropical diseases. I could speak on the burden of NTDs for quite a while, but just a few headlines to give you some context. Globally, roughly 1.7 billion people are affected by NTDs. And of that, 30 to 50% are considered skin NTDs. So NTDs as a whole are 21 diseases, and then we focus on a subset that have skin manifestations, be that rashes, lesions, or other skin discolorations. So that for us includes leprosy, Buruli ulcer, cutaneous leishmaniasis, and yaws. And these diseases are found usually in rural areas and communities that are already facing other challenges such as impoverishment or are underserved by the health system and other services. So why NTDs have been around a while? Why is diagnosing them still such a challenge? And there's a few reasons. One is related to delayed diagnosis for multiple reasons. One is health-seeking behavior. So the initial signs of many of these diseases mimic other conditions, and they may present very early on as mild rashes, a fever, and so people may not believe that their symptoms justify health-seeking behavior. If they do suspect that it could be neglected tropical disease, there's often significant stigma around these diseases, so they don't want to go have that confirmed or be stigmatized in their community. And then, like I mentioned, they're often mistaken for other conditions. And so oftentimes in these rural health facilities, the capacity to accurately visually diagnose or suspect the disease is not present. So they may have a misdiagnosis, have to go to multiple health facilities before they're able to receive the correct one, which is related to limited access. So there's logistical constraints. They may be sent to multiple health facilities before they're given a diagnosis and the availability of treatment for the condition. And then, of course, resource constraints, which we all face, but diagnosis takes a PCR machine, which requires trained staff, which usually requires electricity and a sterile environment, and other factors that many rural health facilities do not have. So that brings in the Biomeme device that we have been working with for a number of years. This is a portable battery-powered PCR device. It's smartphone enabled. You can read the results on your smartphone, and it delivers lab quality results. We've been doing a number of field validations and are seeing sensitivity and specificity that are the same as a lab-based PCR machine. And so this makes it ideal for remote and resource-limited settings. The other big accomplishment here, the thing we're really excited about, is we're able to see results in less than an hour, which in many times has taken days or weeks if they've had to go to another lab, and then the sample can be compromised, and there's a number of challenges that presents. So this delivers results on site in less than an hour. So again, this allows for a rapid diagnosis at the point of care in the communities where we're trying to reach neglected tropical diseases. Again, it's highly accurate. And then through our model of implementation, we've been able to deliver this with, partner it with community-based programs where we're engaging faith leaders, pastors, and lay leaders. And so it's a unique opportunity for us to empower them at a further step along the continuum of care, which results in early treatment and better outcomes if they're diagnosed early and can start treatment. Some of the feedback we've received from our community-based partners is if they suspect an NTD and then are unable to confirm diagnosis or refer them adequately, it decreases their the trust or their reliability in the community to detect these diseases. So having them be able to transition them to diagnosis much quicker is a major success. So I'll share a story. There's a photo here. So this is of a 3-year-old boy in a remote village in the Democratic Republic of the Congo, where we partner with a Christian hospital there. And he's 3 years old and presented with an ulcer on his scalp that was not healing, and came in contact with a program we were already running that's building church network capacity to identify NTDs. And the faith leader was able to connect them with a health worker with the Biomeme device and test on site with his mother and his community and confirm diagnosis, like I said, in less than an hour and start treatment early. For this case of Buruli ulcer, this is especially important to us, where on the African continent, close to 50% of Buruli ulcer cases are in children under the age of 15. So if we can identify that early and stop the progression of any disability, that's certainly a success. So the implementation of this device has not come without challenges and lessons learned. So one is the cost. The device still does cost, sometimes similar to other PCR machines. It's certainly less expensive than setting up an entire lab, but there's assay development costs, the machine itself, training, et cetera. So looking at what are the most sustainable funding opportunities for this. Training as well. Again, this is very user-friendly, but it does still come with training in terms of sample collection. So how do we best equip health workers and our faith leaders, as we've discussed so far this week, to be change agents and equip them with the skills they need to use this device? Integration is another area we're learning a lot about. How is this integrated with the existing health system, with health management information systems, the data, the treatment, the entire spectrum of the health system? And then we're really learning that the success depends on community trust and partnerships, as does all of our work. And then I think where this device and this project, again, why we're so excited about it, is it's doing more than just diagnosing a disease. It's really allowing us to expand access. Again, we're able to deploy this device in many communities that do not have a robust health center and otherwise would not have the capacity to support diagnosis. Again, it's allowing us to empower faith leaders and community health workers, and they're working together. Again, where it may have been a longer, more difficult process if they suspected a neglected tropical disease to being able to refer and confirm diagnosis, we're really compressing that pathway and empowering faith leaders to have a more meaningful role in that. Again, it's catalyzing early diagnosis, treatment, and hope. So with the skin NTDs that we focus on, the sooner we can diagnose and the sooner we can refer and they can receive treatment, that prevents lifelong disability and stigma and the other things that come along with that are so challenging. And then it's advancing health equity. Again, we're bringing this to the communities in which we serve and removing the barrier of having to live or have the financial logistical means to access the appropriate health facility with this device. So where are we going in the future? So we are continuing to scale up. We're focusing on assay development for other diseases and field validation to continue to document that the device is working and working to the global standards that we would require. Focusing on strong partnerships with ministries of health, other NGOs, and faith-based networks that we're training to deploy the device. Funding for both, which still in very much a research phase, so funding for the research and the field validation that's required, and then for the deployment as well. Focusing on appropriate training methods and modules in different contexts, again, for health workers and faith leaders. And then advocacy, so working with partners like the World Health Organization to have this device be the gold standard in neglected tropical disease diagnosis, but other diagnoses as well.
Thank you so much. Thank you so much. Before I introduce the next speaker, I would like us to stand. I know after lunch where I come from, the productivity scale is usually empty. So we are going to write the cross using our body, and you'll follow me. So the cross is from down, then you stand, and then you go on the side and you cross. So I'll give you a sample. Down, then you go on the side, keep it there, then you cross. Okay, let's go. Go down, yeah, then up, then make a cross. I'm seeing with your body. Yeah. Thank you. Thank you so much. Yeah, so the next speaker is Naomi Macau, who is the program and M&E manager for World New, presenting from pens to pixels. Thank you. You're welcome.
So yes, I'm presenting on behalf of World Renew, and we have a beautiful stand out there for you to learn more about us, but for also to be able to win your bingos. We are helping you with that as well. So in World Renew, we are becoming and we have continued to be more intentional and more focused from moving from data collection that is manual and paper-based to digital data collection. And so today I'll be sharing a case for one of our projects in Kenya that just describes how the process has been, what we have gone through, what we have put in place, and what you can learn from us. So a little project background. The project that I'm going to be giving a story on is located in the coastal part of Kenya in Kilifi County, and it's more on improving maternal and child health, nutrition, and reduction of teenage pregnancies. We do this through promotion of ANC, postnatal care, delivery in facilities, nutrition, immunization, and access to health facilities. And how we do this is we engage with the community through community health promoters. And in Kenya, the community health strategy that we use, the community health promoters are volunteers that work with the community that work in the community health strategy, and they're the ones who promote, the knowledge and collect the data that we use from the beneficiaries. So why was this important for us in Kenya? One, we realized that the community health promoters spend excessive times on data collection, especially through paper data collection. We also realized that our data quality was really poor because of how we were collecting it. So much of it was incomplete, and it was not submitted in time, and it was also inaccurate. We also realized that there were high risk of errors during the data collation and aggregation, and also there were limited use of collected data by stakeholders, and also we had a lot of loss between when we collected the primary data and when we aggregated and how we kept it in the field. And so I attempted to put a small video to just show the process of how we began and what we have learned so far.
Imagine trying to collect health data accurately and precisely with a pen and paper, while trying to teach a pregnant woman on the importance of delivering their baby in a health facility than from her house on a hot afternoon in a remote village. Now, imagine replacing the data collection with a smartphone that collects the same data instantly, accurately, securely, and with minimal errors. At World Renew, we've made that shift from pens to pixels. In our work in Kenya, together with our partner ADS Funding, our MNCH project supports over 3,000 pregnant and lactating mothers across 12 rural communities in promoting health and nutrition in part of Kilifi County. As we began our quest to deliver better health services, we increasingly desired quality data, timely, accurate, precise, complete, and easy to analyze for better informed decisions at all levels. Manual systems were cumbersome and made it hard to track progress in real time. So we turned to digital tools that are free, open source, and easy to use. Together with a consultant, we created a simple and friendly to use digital data collection, aggregation, analysis, and output system. This comprehensive system uses Kobo Toolbox, R, and Shiny App, which are all free and open source tools and blog. Here is how it works. Community health promoters, who are community volunteers in the Kenyan Community Health Strategy, use smartphones with easy-to-use digital forms built and posted on Kobo Toolbox, available in multiple languages to collect data during home visits. This system allows for offline data collection. Once connected to the internet, the data is automatically sent to a secure online reserve. From there, the system cleans and organizes the data using preset rules, so you don't have to take time to do it by hand. Then, the cleaned data is scanned into clear tables, charts, and dashboards that show us what's happening in real time. This means project staff can see data as it trickles in, like which mother needs help, what areas need more attention, and how the overall health project is doing, without waiting weeks for someone to search through months of paper. What has changed? A lot. Data protection through set and controlled access protocols and safety standards. We now get accurate, reliable, incredible primary data from the community. Our decision making at all levels has improved. The community health promoters are able to assess the progress in their specific villages. The health facility is able to determine areas that need more mobilization for services. The county medical team has a more accurate picture of progress in the project areas. And for us and our partners, we are able to confidently track achievement of our targeted outcomes. Our community health promoters are spending much of their time in conducting more time and targeted interventions with beneficiaries at the household level. And the system is inclusive. Project staff who have no technical know-how on data analysis can comfortably view trends, download reports, and understand patient impact. Sure, we have faced a few challenges and hurdles, like Coco Toolbox 1 GB limit for media uploads, but overall, the system is scalable, efficient, and ready for growth. At World Renew, we believe that better data means better interventions. By embracing digital innovation, we are helping communities live healthier lives, one click at a time.
So in summary, one of the things that we've definitely learned is that digital data collection doesn't require high literacy levels. Like I mentioned earlier, we work with community health promoters, and in the Kenyan context, the community health promoters are not necessarily literate, members of the field or the health field. They're mostly volunteers who are happy to support in, aspects regarding health. And these are the ones we work with, and they've been able to use this tool very efficiently. Again, setting up the digital system has been very affordable for us and sustainable. This is because, like I mentioned in the video, we've been using open source, freewares. That's what we've been using to set up the system, and that has worked really well for us. Digital systems for us has reduced data collection time and has enabled the community health promoters to focus more on the interventions. Before, it was really hard because they'd have to, set aside time to interact with the beneficiary, but at the same time, set aside time to be able to collect good data. But now, at least, they are spending way less amounts of time in data collection, and hence, they have some very good amount of time that they can spend in interacting with the beneficiaries. Again, our quality of data has really, really improved. We no longer, we still do a bit, but we've really improved in accuracy, in completeness, in timeliness on how we receive the data. Like I mentioned earlier, we're able to track how data comes in real time. And so that has really been useful for us. Again, because the data is real time, it has been more useful for decision making. We really don't have to wait long periods of time to be able to track the changes that the project gives or retract where we feel that the interventions are not doing what they're supposed to be doing. So thank you very much. I think that's my last slide.
Thank you so much for the wonderful presentation and the video that was well crafted. So at this point of time, I think I'm going to have all the speakers come over here, and then we can be able to have some questions. One more chair. Okay, okay.
Owen, I'm with LifeNet International. World Renew, I'm just curious. I know Kenya has a system called eCHIS, that community health promoters work. I'm just wondering how your system integrates with that. And then I was very interested in the sisters training. It looked like there's an ability for self teaching in your program. Can you tell me, is it like Moodle based and how that works?
Yeah, my name is Obi from Nigeria. Follow up from what you asked. It would be nice to know, give us an example of the type of data you collect. I know it's nutrition, I know it's maternal, but what do you really ask them to get that information, since it's digital? Thank you.
Thanks, Professor. We'll just take this and then we'll come back for another round.
So maybe I'll start from the last question on the type of data we collect. So we are collecting both routine data, so primary data that has the output indicators and the outcome indicators. For example, like you said, in nutrition, would be collecting how many of our beneficiaries have kitchen gardens, for example. Would be collecting how many of the lactating mothers are tracking or are conducting exclusive breastfeeding, for example. We'll be collecting data like how many pregnant women are accessing antenatal care. So that's the kind of data that we'll be tracking for primary routine data collection. When it comes to evaluations, we'll still use the system to collect the larger outcome indicators on what changes are we already seeing. Yeah, so for example, we'll be saying, are we seeing like more complementary, feeding where nutritious foods are being introduced in, the diet of the pregnant women, of the children and the like. So that's the sort of data that we collect. So at routine data, we collect output level data, but at survey, we'll collect the outcome level data. And then in regards to the government, I think you mean the government system. So in regards to the government system, because I said we work with the community health promoters who are required to use the government, protocol. So we are in collaboration with them, and some of the indicators are actually co-shared. And so what we end up doing is that we frame the indicators in ways that the community health promoters get to understand, because they're not using the same digital tool. The government does not allow us to use the tool. And so what we try to do is that we try to synchronize the language as much as possible, so that as the community health promoter is engaging with the beneficiaries, there isn't, a diversity of indicators that they are trying to track. I hope that answers.
Hi. So the program has a couple of components. The main component is the courses online. Those are asynchronous, so they are able to do it whenever they want. We don't have Moodle. We have another platform called Osmore, but works the same way. They have lessons, they have self-assessments, and at the end of each course, they have a 10-question quiz. And besides that, we have weekly meetings that they're not obliged to attend. They're recorded if they want to. The last cohort that we had a whole series on psychosocial support for communities and faith-based. And each cohort, we try to invite guest speakers to do a series on a topic that actually comes out of the questionnaires that the sisters answer at the end. All participants answer at the end of each path. We have a questionnaire on satisfaction and what other themes they would like to learn about. And they also have the WhatsApp support groups where that's where it's active all the time. They get to interact with each other. They get to promote whatever activities they want to promote. And they get to ask a lot of questions also. And yeah, so those are the 3 components.
She wants to attempt.
We can only speak about the students that we've been able to support during the first year of implementation. And as we explained in the presentation, The PFA agents, which are actually trained teachers that are in school and interacting with the students on a daily basis, they are able to communicate and perceive when they are at risk of a mental breakdown. So what we're trying to do with these agents is identify the need and provide that first support to address the crisis. And once that is addressed, then if there is a need, then we provide more, psychological support as needed, or any type of special attention that the students might require. I can't speak to what we see and who interacts with our website and our platforms, but at least the individual support that we provide through the students, it's carefully vetted.
Thank you. I think we'll be able to have a follow-on after the session for more. There was another question.
So quick question to three of the four of you. So first of all, on the educational systems, I'm wondering whether you have or have considered any sort of partnership with somebody who would be able to issue an official certificate for any of the training, because it seems to me that in some cases, people being able to present the fact that they've been certified in one of these topics may be a really useful tool. Second, regarding the PCR, very simple question. What is the per sample cost of the testing as you're doing it now? And recognizing that with economies of scale, hopefully that would come down. Do you have a target per sample level that you believe should be achievable with this tool? Being as I am involved in global health security, I'm super excited about anything to do with remote and non-point of care diagnostics. And then finally, just to follow on with your question on the previous question on the Kenya tool, is there any discussion with the Ministry of Health on ways that the actual data that you have captured, you mentioned the common data elements, is there any way that those data can be shared, submitted somehow into the system to strengthen the overall reach of the Kenyan surveillance systems? Thank you.
So maybe I can go first so that I don't forget. Yes, I think from how we already implement our projects, we are implementing the projects together with the government of Kenya, and especially with the sub-county health committee that is charged with the health project implementations in the county that we are currently operating in. So part of the data that we collect, and I think in my video I alluded to that, the part of the data that we collect is already helping them in making decisions, because the mechanism that we have, the government may not have. And where we are reaching, based on the structures that we have at grassroots level, the government may not be very privy to that. So we are very intentional in making sure that we have all this round table very regular to be able to say to the government that this is what we are already saying, this is what the data is saying. We actually have gone ahead into conducting joint monitoring activities with the government, where after that we are able to review the data that we've been collecting. So yes, thank you very much for that, because it's been really working well for us. Thank you.
Thank you for your question. Because of time, I was not able to talk about that. But the other step that we're working towards, besides mentorship, is looking for an accreditation and maybe some sort of liaison with a college or university. We do, at the end of each learning path, the student does get a certificate from us, but obviously a lot of students ask, can I get credit for this? How, what's the takeaway besides me learning? Because it's obvious that that would be a benefit. So yes, we are looking into it. So if anyone has any ideas, suggestions for me, I'm open to it.
Sure. And then regarding the PCR costs, currently, if you take into account the assay manufacturing, the DNA extraction kit, all of those components that go into it, I could be wrong, but I think we're around $20 a test right now, and would love to see that cut in half. Again, there is an economy of scale. We look at different assay manufacturing. Another component we're looking at that I think will decrease that cost and increase the economy of scale is multiplex capabilities. That's one of the requirements. You may be familiar with the target product profile. And so we want to make sure that we can address that. And there's a study ongoing currently.
Thank you so much, everyone. I'm about to give myself a red card. Before I do, I would like us to give a big round of applause to the speakers. Thank you so much for the wonderful presentations. I know that we will be able to have these resources shared to us from CCIH so that we can be able to also have an interaction with the team. So thank you so much. We should clap again for the teams as they move back to their seats. Before they do, I always want to steal a photo moment like Mona. So I would like to invite anyone to take a photo of me and the speakers and any other person who wants to join us. Thank you. So as we do that, we have a break from now up to 3. We are going to get back for devotion as well as the evening reflection. Please join us. You can stay. It's just a short time.
Oh, thanks.